Hello, everyone. Happy Monday. Welcome to another one of the VMRs. I think we're up to more than 1,000, which is just so amazing. And I'm so excited to discuss alongside Youssef today. I was just saying that usually, I'm so used to discussing on Sundays in the student VMR, so I was about to give the spiel for the student VMR, but this is not a student VMR, just a regular old Monday VMR. But yeah, for those who I don't know who may be joining, I'm Maddie, and we're going to be co-discussing alongside Youssef. And we have a rock star team who's making this happen today with Julia and Parisa on scribing and teaching points, and the one and only Mark who's presenting a case. So maybe we can, hear just your voices of everyone who's making this session happen. Julia, do you want to unmute, maybe share where you are and anything that's going on with you today?
Sure, thanks, Maddie, for this great introduction. You're the best. I can agree totally. I'm just very happy to see you all, and it has become a ritual for me. And I'm excited each and every day for another great discussion, and I never get disappointed. So I'm also excited for today.
Thank you so much. And Parisa, what about you? Do you want to unmute and share what's going on with you these days?
Hello, everyone. It is Parisa. I'm IMG from Iran. I'm so excited for today's case. Mark is presenting, Maddie and Youssef are discussing. It would be fire today.
I'm so excited. And Mark is in the middle of his workday. Mark, do you want to unmute, share what's going on with your life for those tuning in?
Hey guys, I'm Mark. I'm on a week of hospice at the community hospital. So I'm having a lot of time doing a lot of fun doing direct care this week. Kind of in the middle of a busy day, but I'm happy to step away and present this case that I had a couple weeks ago. I got a few cases that I picked up last week. I'm going to present over the next couple of months. So I'm super excited about it.
I'm so excited to learn from your case, Mark. Youssef, how you doing?
Hi, Maddie. Hello, everyone. I'm Youssef. I'm also I am graduate, just started hospital medicine recently. Maddie and I have been working together for almost a year and a half, and we co-discussed maybe only 2 times or something. It's It wasn't that common. So I'm so excited to co-discuss with you, and Mark. Excited for your case. How was your day, Mark? Are you done?
I'm almost done. I we end our day around 3. I'm a little busier today, so I'll probably be around like 4 o'clock. But yeah, it's been a good day, busy Monday.
All right.
Well, let's jump into it. And Youssef, I agree. I think we need to discuss more together. All right, Julia, thank you so much for scribing. Oh, and thanks for sharing your screen. Julia, we're not seeing the whiteboard yet. We're seeing an EM crit page.
EM Crit is the best.
Yeah, great resource. I wonder if it's a different tab that you have open. Perfect. You're all set. Thanks, Julia. All right, Mark, all you.
All right. So I kind of want to be like authentic as possible in this case, kind of like Robbie and Reza do on their RL podcast, how the data came to me, as this was my first moonlighting shift as a hospitalist. So super excited. I got off a week of like at the community hospital and had a couple of days off, and I was really excited to just like focus on like admitting interesting patients to the hospital. So I'll kind of get to tell you guys the data as it came into me from the emergency room, but kind of the chief complaint for this patient. So this patient's a 68-year-old female, and they're presenting with 2 months of abdominal distension and 1 day of generalized weakness.
All right. Youssef, if it's over, I can take the first talk and pass to you, and then we can alternate. Yeah, 68-year-old female with 2 months of abdominal distension. We will definitely kind of talk about a schema for abdominal distension, but just to mention, one thing that stands out to me is the time course here. The fact that this has been going on for 2 months is really interesting to me, because I'm always curious about what triggers a patient to present to care. And so if this has been going on for 2 months, I would be very curious to see, really what prompted this woman to seek care after 2 months of these symptoms. I'm seeing kind of 1 day of generalized weakness. So I'm wondering if it was the weakness that prompted her, but I'll be very curious to kind of understand how this has evolved over the past 2 months. But so for abdominal distension, I have really loved the kind of phases of matter approach to abdominal distension. So is there distension because of a liquid, a solid, or a gas? I found that just a very helpful way to approach abdominal distension. And so to go into those a little bit more in depth. So if we think of liquid, what are some of the liquids that could cause abdominal distension? Some of the things I think about are, could this be ascites? Does this patient have, portal hypertension, cirrhosis, and there's ascites causing this abdominal distension? Some of the scary things is there kind of blood in the peritoneum, hemoperitoneum? Or, is this urinary retention as kind of a liquid causing this abdominal distension? So that's liquid. Solid, is there some type of organomegaly that's causing this abdominal distension? Or and then gas, I think of a obstruction in the GI system. So some kind of practical ways that we could make progress on this is, to evaluate for, could this be urinary retention? You can get a bladder scan. That's one very easy way to kind of rule out that. And of course, if this was ascites, you would be looking for signs of kind of chronic liver disease on exam. So that is kind of my first past approach to this. Youssef, I'll pass the mic to you to see, if we can make additional progress, given that this has been 2 months, 1 day of generalized weakness. How are you thinking about that?
Thank you, Maddy. I don't think I have a lot to add in terms of differential diagnoses, but I think I also use the phases of matter approach. The other framework to think of is most common and no miss diagnoses. So most common in terms of abdominal distension is going to be things like cirrhosis, for example, or heart failure is very common in the general population, especially with the prevalence of alcohol use and especially that it's like subacute to chronic. I think of things like cause ascites as like most common, and things that are no miss are causes of obstruction, like you mentioned, and so similar framework. And then in terms of weakness, I'm trying to think of, is this weakness as in, does the patient have asthenia? Do they feel weak, or is this actual weakness where they can't move their hand or their leg, which is more localizing towards a neurologic lesion? But these are my general thoughts, and the things I would do are like a physical exam would be very helpful to diagnosing ascites, for example, like shifting dullness is classically like very diagnostic, and then just putting a probe or an ultrasound and looking for fluid is a quick way to differentiate between the diagnoses.
Yeah, no, totally. And Yusuf, as you were talking about, I was just thinking of, how we can kind of prioritize these given the 2 months. And, I was thinking that I feel like, if this was a bowel obstruction, I don't think the patient would this would be going on for a total of 2 months. Hemoperitoneum, I think there would have been some kind of consequence and causing her to present to care earlier. So I think I'm most curious for ascites here, given the 2 months, the 2-month time course, but we will see. Mark, back to you.
Awesome. So I'm just going to tell you what the ED told me in sign out, and then the vital signs and labs that I saw before I went and saw the patient. So essentially, the ED, or it'll be easier probably to give you the CBC first to kind of frame this. Essentially, the first lab I see in the chart is a CBC. The white blood cell count is 5.2. The hemoglobin is 4.3. The platelet count is 175. The MCV is 104. A prior hemoglobin, 8 months prior, was 11.1 with an MCV of 92. And then essentially the ED said that, this patient is getting admitted for anemia, but they did not transfuse because the patient has a history of heart failure, is the sign I got. And the other data I saw was the BMP, and they told me that the patient had a history of ESRD. So the BMP showed a sodium of 137, potassium of 4, a chloride of 94, a bicarb of 29, a BUN of 35, a creatinine of 8.4, an anion gap of 14, and a calcium of 9.9. And like I said, this patient is on dialysis. And then the labs that I saw on the chart was afebrile, a BP of 117/83, a heart rate of 69, and an SpO2 of 99% on room air. So that's the sign I got. I told you guys the sign out. I'll tell you the labs and the vital signs. I have no other labs in the chart, no imaging. And really not much contact with the medical system since that last CBC 8 months ago. So I'd love to see where your guys' head is at now. And like I said, I want to be as authentic as possible because a lot of you guys might be interested. I'm sure most of the people are interested in internal medicine, maybe people interested in doing inpatient medicine. And this is a lot of times, you know, when we're in the hospital, we get the objective data first, and then we kind of go and talk to the patient after. So I think it's always interesting to think about cases from that lens.
Wow, thank you so much, Mark. What a powerful start to the case. So it sounds like here we have a lot of information that jumps to us just before delving into them. We see like abdominal distension, weakness. We see this hemoglobin of 4.3 with an MCV that's elevated, and the rest of the labs are, from what I can tell, like normal or close to normal. And the way to make progress here is either we can choose either the most severe abnormality or the abnormality with the most narrow differential diagnosis to help us go closer to the case. And if I were in real life taking care of this patient, the thing that would jump out to me would be the hemoglobin of 4.3 with that is macrocytic with an MCV of 102. Is that right, Mark? Okay, so in general, we see here anemia, and the causes of anemia are either blood loss through like bleeding through the GI tract or other bleeding or internal bleeding. That's the first etiology. The second etiology is like hemolysis, and the third etiology is underproduction. And we can try to figure out which etiology it is by seeing the rate of the drop, which makes you think of bleeding, but although hemolysis or underproduction can also cause significant drops in hemoglobin, but the bleeding is the most life-threatening. The other things we can think of, for example, is the heart rate. Like if this patient was actively hemorrhaging large amounts of blood, you would expect the heart rate to be elevated, like close to like the 100s, for example, at least, because that would be like the sympathetic response. But it looks like here we have a heart rate that is normal. And we don't hear a history of bleeding, although we can go into it further. The other thing is they have a history of end-stage renal disease, and patients with end-stage renal disease are at risk of anemia through underproduction because they don't release EPO through the kidneys, and then that causes anemia on its own. And in patients with end-stage renal disease, a lot of times there's an indication to transfuse and give them EPO, especially if the hemoglobin is under 10. But patients with end-stage renal disease frequently have frequent CBCs because they usually get their blood work checked if they're going to a dialysis center, for example. So usually we would have a baseline. So it might be helpful to see if we have a previous hemoglobin that is closer, but it sounds like the last one has been a while. The last thing I also thought about is that we hear that this patient is on dialysis. It would be interesting to see as well if they're on peritoneal dialysis or hemodialysis, because if they're on peritoneal dialysis, they would get dialysis through the peritoneum. They would expect that they might have some degree of abdominal distension, for example. They might develop complications related to that. And then lastly, with the Maddy, I'm going to leave it to you, the discussion about the MCV and how does the MCV make you think of?
Youssef, that was such an awesome discussion. I love that you just kind of outlined the framework anemia and then kind of incorporated the history of ESRD, etc. And I also, one of the things I love that you mentioned was kind of clues to the time course. Like, are we getting some clues? Do we think this is an acute anemia or chronic? And I love the point that you made that with an acute and anemia, you would expect there to be an elevated heart rate as an example, but the fact that this patient's heart rate is 69 makes me suspicious that this is not acute and perhaps this has been ongoing for some time. So I'm a little bit more concerned for a more chronic anemia. And yeah, I think for, the additional information that Mark gave us was the MCV that was elevated, so a macrocytic anemia. And when I think of a macrocytic anemia, I think this could be megaloblastic versus non-megaloblastic. Megaloblastic meaning that there's some type of impaired DNA synthesis. So I generally think of kind of vitamin B12 deficiency, folate deficiency, and then some of the non-megaloblastic causes are things like alcohol use, hypothyroidism, some drugs, and liver disease. So I think in terms of what I would do next, I love the point that Youssef made that if this person is getting dialysis, I would expect them to kind of be getting labs at those times. So I would also try to dig through the chart to see if we have any, additional hemoglobins between the 11 and the 4.3 to understand the time course of this. And then I would send off a lot of labs to understand the etiology of this anemia that Youssef walked through. So Youssef walked through kind of this underproduction, is this peripheral destruction, is this blood loss? So I would want to get a smear, for example. I'd want to get a reticulocyte count. You could send a ferritin as well. Those are some kind of initial studies I would get to more thoroughly evaluate what's been going on. All right, Mark, I'll pass it back to you.
Oh, I wanted to add as well, Maddie, like I love your approach as well to like macrocytic anemia. The other things I think of as well are I wonder why this patient has end-stage renal disease, because if they have like a myeloma, for example, or paraproteinemia, that can cause macrocytic anemia. It's most cases are normocytic, but 20% of myeloma, for example, are macrocytic. So that's one thing. And then the other big category of that causes the macrocytosis is reticulocytosis. So if you have a fast turnover, for example, then that increases the MCV, although the MCV is usually higher, like closer to 126. And then alcohol use is very common to cause a mildly elevated MCV, and copper deficiency as well can cause anemia, and copper deficiency can cause macrocytic, normocytic, or microcytic anemia.
Amazing. All right, Mark, back to you.
Awesome, guys. So like I said, I'm going to be authentic to my journey. So I'm like power walking to her room. I'm completely lost in my new hospital because it's kind of a maze over here. I have no idea where I'm going, asking everyone where to go. But I land in the emergency room. First, anytime I walk in the ER in a patient's room, especially someone that I'm a little worried about, I always take a look at them, kind of get that like sick or no sick, or sick or not sick, impression from the door. And the patient was kind of lying with her eyes closed, looked a little somnolent. Her daughter was at her bedside. And then for her vital signs, I always take a look at the monitor for the vital signs. Blood pressure was similar to I mentioned, had I think I mentioned like 110s over 80s, but she was tachycardic in the low 110s. And I noticed an irregularly irregular rhythm on the monitor. And then I talked to the patient and daughter at bedside. And essentially they corroborate that history. She was doing well until about 2 months ago, where she developed this abdominal distension. Has kind of slowly progressed over time. She's not having any issues with PO intake. She's eating and drinking just like she normally does, despite this abdominal distension. She's having bowel movements regularly. She denies any signs and symptoms of bleeding, melanoma, hematochezia, hematemesis, anything like that. She said she's not, despite the abdominal distension, she says she's not gaining weight. As Youssef was getting at with the asthenia versus like neurological weakness, she just said whole body weakness, even present when she's just there at rest. She does have some baseline dyspnea on exertion, which after she walks a few steps, she'll get dyspneic, and then she has no dyspnea at rest. That has been stable for years, no change in that. I can give you guys some of the past medical history as well and the medications, unless you guys want to discuss that before the past medical history and meds. Keep going. Okay. So past medical history, history of ESRD. I knew at the time of what the cause was, but I'm blanking on it right now. But I'll say it's not too relevant to like the final diagnosis. She has a history of heart failure with reduced ejection fraction. Her last EF was 30 to 40%. A few months prior with severe tricuspid regurg. She has paroxysmal atrial fibrillation on apixaban, hypertension, prediabetes, and hyperlipidemia. Her medications, let me see, I just have them on my phone. She was on apixaban, dose reduced for ESRD 2.5 milligrams twice daily. Actually, no, she was on 5 milligrams twice daily. She was on a calcium supplement, lisinopril, and metoprolol. And no relevant allergies, no really relevant family history. And then she did not smoke, she did not drink, and she lived at home with her daughter.
Thank you, Mark. And do we have the dialysis history? Like, was it peritoneal or was it like intermittent hemodialysis?
Intermittent Tuesday, Thursday, Saturday. And I believe this was on a Wednesday, and she got dialysis the day prior.
Yeah, Mark, thank you for so kind of authentically walking through this. I feel like I could imagine kind of being with you walking down to the ER, and as an intern, I totally understand being lost in a hospital and taking like 20 minutes to find the ED. So let me, you've given us a lot of information, so I'm going to just take a second to summarize everything. So we have a 68-year-old female, a history of ESRD on intermittent dialysis last session the day prior, heart failure with reduced ejection fraction, AFib and pre-diabetes, who is coming in with a 2-month history of abdominal distension, asthenia, and dyspnea on exertion, which seems to be her baseline, if I heard that correctly, who is found to be severely anemic to 4.3, is found to have a macrocytic anemia. And that's how I would kind of summarize where we are right now. So I'm trying to think kind of where to go from here. I think as Youssef said last time, when figuring out which direction to go down when thinking through a case, you can either focus on what is the most kind of drastic abnormality or one with kind of the more limited differential. And I still think that the hemoglobin of 4.3 is the most striking and concerning abnormality. So that's still kind of the center of gravity in my mind. Though, we do need to explain why does this woman have 2 months of increasing abdominal distension? And then Mark, one clarifying question. Do you mind clarifying, is the dyspnea on exertion, is that baseline? Has that been worsening for her? Just wanted to clarify that.
Been stable for as long as she could remember. Yeah, and I really tried to push her on that for a few reasons, but yeah, just that's been completely stable, and no new orthopnea, PND, no new leg swelling. Yeah, dyspnea is stable.
Yeah. All of those additional kind of details that you gave just now were really helpful because, when we go back to the abdominal distension, kind of the solid, the liquid, the gas, and some of the liquid, the kind of differential, we were talking about ascites as an example. And, for ascites, you can think, is this, portal hypertensive versus non-portal hypertension? And one of the causes of kind of abdominal distension and ascites is you can have congestive heart failure that's causing that. And so that's why I was curious if I was kind of listening to see, has this person had increased weight gain, which is not present, no worsening dyspnea on exertion. So, that I'm still considering, could a congestive heart failure process be causing this worsening abdominal distension, but given the fact of no PND, no weight gain, no worsening dyspnea on exertion, I'm putting that a little bit lower. I'm still curious how, I think anemia is something that we need to explain here. And I talked about some of the labs that I would order to make progress on that, but I'm curious, Youssef, if in your mind, you're able to link the anemia with the abdominal distension. How are you thinking about that?
Yeah, Maddy, thank you for the discussion so far. I'm not sure they are necessarily related. I'm trying to think of ways they are related and ways they could not be related. So if they are related, we were mentioning causes of bleeding, for example, or splenomegaly, etiologies like that. But also, the prevalence of anemia is so common in patients with end-stage renal disease that it's hard to necessarily link it to any other symptom. So they could have anemia and another process going on. The other thing that's puzzling for me is that usually in patients with end-stage renal disease on dialysis, their volume is managed via the dialysis. So if they're getting like dialysis every 3 times a week, you expect that they would be able to get some volume off. So if this is just heart failure and the patient has always been getting dialysis persistently, I wonder why it like necessarily like accumulated. Is this a component of like worsening right heart failure, given that they have this tricuspid regurg, this AFib as well? Is the right heart failure worsening and causing the accumulation of the ascites? The other thing I think of is additionally, like why do they have this heart failure with reduced ejection fraction and the end-stage renal disease? Could this be like a component causing like we still don't know if the abdominal distension is this fluid or is this like organomegaly, and I think that would be like a good branch point to start off, because I think if we know that this is ascites, then we can go down that route. But if we think this is like, if we get an image and this just says like hepatosplenomegaly, I think that would like change the differential completely. That's where my head's at. The other thing is we see like apixaban use that puts the patient at risk for bleeding as well. And then the other thing that's like common in real life is iron deficiency. Patients with heart failure and end-stage renal disease are at risk for iron deficiency, and we use a higher cutoff for the ferritin. So we use a cutoff of 500 for end-stage renal disease and a TSAT between 20 and 30 for patients on dialysis. So it's a higher cutoff for general patients, although that's anemia is usually microcytic. Classically, here we see like a macrocytic anemia, and then we don't see any alcohol use that can cause like a macrocytic anemia as well, and no other like risk factors. And then the other thing is, could they be having like valvular disease with like hemolysis at the valve, for example, as classically seen with like stenosis instead of regurg, and we don't see any like valve replacement or anything like that. But I'm curious to hear more, Mark.
Yeah, you guys had my exact thoughts as I was stumbling through the ER. So I'll let you guys know about the exam next and some additional labs. So I mentioned the vital signs. And so just generally, patient was like tired appearing. I mentioned a little somnolent, but it would awaken to a voice. HENT exam definitely had significant conjunctival pallor. Neck exam, I didn't appreciate any JVP. Cardiac exam, like I mentioned, tachycardic, irregular, which matched when I was looking on the telemetry as well. Didn't really appreciate any murmurs. Pulmonary exam had normal respiratory effort, some crackles, faint crackles at the bases, like I mentioned, normal effort. And then her abdominal exam was rather tense and rather hard. With no pain at all, though. I pressed pretty hard and she didn't have any pain, but rather tense. I didn't appreciate really a fluid wave, and really tough to appreciate like organomegaly with like just how tense it was. An extremity, she was warm and well perfused, no edema. And then on neurological exam, she was AOA ×2, so she knew her name. She knew she was in the hospital. She said that it was 2014 and she didn't know the president. And when I was asking her daughter, which is always helpful, family at bedside is just wonderful. She said that this is a little off of her baseline. Maybe since the weakness started, that she was getting a little more somnolent and a little confused. She wasn't that concerned, but definitely like a little off the baseline. And then I'll mention some of those anemia studies that you guys wanted. Let me just pull up my labs real quick. Right. All right. So, hold on, let me just. So at first was the reticulocyte count. So the absolute reticulocyte count was 123,000. Let me get the percent for you guys. And the percent was 8.8. The ferritin was 1,140. And the transferrin saturation was 15%. The B12 level was 962. The haptoglobin was 105. the LDH was elevated at 274. The D-dimer was elevated, was greater than 20, which is above our assay. And then the INR was 1.9. I don't have a previous INR while the patient was on apixaban. I only have one that was 1 in 2021. The patient was not on apixaban. And then I'll also just give you the liver function test as well. Sorry, I'm kind of just looking at the chart right now. 1 second. Okay. So the AST was 52. The ALT was 14. The total bili was 1. The albumin was 3.8. And the total protein was 8. And I'll stop there.
Maddy, do you want me to take exam, you take labs, or do you want to take the opposite, whichever you prefer?
Go for whatever you want to tackle first, and I'll just add to what you don't talk about.
Okay, that sounds good. We can go back and forth. So just on exam, it sounds like the patient has is tachycardic with AFib, and we see that the rate is in like close to the 110s. And then on the abdominal exam, it sounds like we have 10s possible ascites. And the patient is oriented ×2 with no obvious like focal neurologic deficits, which makes us think of why is this patient like confused? And this we usually use with CPSR as the missed mnemonic, like metabolic, infectious, structural, and toxic. In terms of metabolic, with the ascites, we're wondering, could there be a component of liver disease or portal hypertension? In terms of infectious causes, we don't see any fever, although we see possible signs of inflammation. The ferritin is very elevated. For structural causes like ischemia, this patient is at risk for stroke because of their AFib, even though they are on anticoagulation. And then for toxic, I also think of things like ingestions or medications, although we don't see any obvious causes. In addition, Maddy, I'm going to have you start with the labs, and then I can go back as well, discuss with you.
Okay, perfect. Yeah, so we got a lot of helpful information here to think through anemia that Mark gave us. So just to kind of go back to the framework that Youssef talked about at the beginning. So for anemia, you can think of underproduction, you can think of blood loss anemia, you can think of peripheral destruction like hemolysis. Starting with hemolysis, some of the things we look out for is that would be consistent with that is a low haptoglobin, an elevated LDH, and indirect bilirubin. And we're not seeing that here. We're not seeing that the haptoglobin is decreased. We're not seeing an indirect hyperbilirubinemia. So I think the hemolysis, peripheral destruction hemolysis category is less likely in my mind. Then the question is there some type of blood loss anemia? Is there an underproduction? So, thinking about the underproduction category, if we're thinking about a bone marrow process, generally in my mind, I would expect multiple cell lines to be down. And we're seeing that it's just an isolated anemia, which is something that's standing out to me. And then we look at the reticulocyte count and percent. And, my impression looking at those labs that there's you can kind of calculate the reticulocyte index, which you generally pull up MD Calc for but my sense from the reticulocyte absolute count and percentage is that this would be appropriate kind of compensation. Youssef, I'm curious if you agree with that, but we're not seeing like a low reticulocyte count. So I'm thinking that would be an appropriate compensation. So, the underproduction category, I think I'm also less concerned for, given the appropriate reticulocyte count. Then the question is this blood loss anemia? And there's from the history, we're not hearing about any hematochezia, hematemesis. So, as I'm talking this through, I'm not entirely sure what the cause of the anemia is, but I think I would still want to get a peripheral blood smear. And that's what I would say about the anemia. Maybe I'll pause there, Yusuf, and just curious if you had any like a different interpretation of those labs.
I had a similar interpretation, like the haptoglobin is normal and which is reassuring, although not like completely sensitive. The thing that jumps out to me that's very reassuring is that I don't think this patient has cirrhosis. So if you just look at their platelet count is normal. Their albumin is normal, and their INR is slightly elevated, but they are on apixaban. And these are usually sensitive markers for cirrhosis per se. But that does not mean that the patient doesn't have portal hypertension just from heart failure, because they are at risk for worsening heart failure with their AFib, their TR, and that could cause ascites through portal hypertension through right heart failure without cirrhosis. But that jumps out to me as well. And another hint is that, for example, in cirrhosis, the haptoglobin is really low. We don't usually test for cirrhosis through haptoglobin, but that's like a reverse trick to think about it as well. In terms of the anemia, I'm still not sure. I also not sure where the center of gravity of the case is. Like did this patient just have worsening heart failure and they now have ascites? Are we gonna make sure that they're not bleeding into anywhere in their abdomen or into the GI tract? I think for sure. And then the other thing is, do we need to get like a diagnostic paracentesis after we get an ultrasound if there is fluid there? These are like my big thoughts, I think for now. In terms of the ferritin, so the ferritin is elevated at 1000 with a low TSAT. I've read about this in many sources that usually if the ferritin is elevated and we have a low transferrin saturation, we usually diagnose anemia of chronic inflammation. However, there are like some experts who say that if the ferritin is above a certain cutoff, it's usually harder to diagnose anemia of chronic inflammation. That cutoff varies between like 500 to 1000. Depending on like the resource you found, but I don't think that's like a solid data behind it. But I know like for sure that this patient has like a component of inflammation with the ferritin. So I wonder about chronic conditions. I'm wondering why they have like end-stage renal disease and why they have heart failure. So I want to dig back in their history, see if they have ischemia. And the other thing is I would want like an SPAP and kappa and lambda as well. And then we still don't know why they're confused as well. So we also get like an infectious workup and an ultrasound of the abdomen as well.
Back to you, Mark. Such an interesting case.
Yeah, no, this is awesome. I'm just curious, what would you guys do next? And I guess I actually have two questions. I think this would be really great for the group, and things that I was thinking about during the case is that, so we have a hemoglobin of 4.3 in a patient with severe TR and EF at 30% and ESRD. And then also, what do you guys think about the reticulocyte? You guys, alluded to it, but the reticulocyte count of 123,000 in a patient with ESRD. And this could just be more of a read my mind, like but
yeah, let's see. In terms of I guess to address the question of the reticulocyte count of 123,000, is that right, Mark? Yeah, that seems severely elevated. And in ESRD, like Yusuf made a good point that you can have low EPO, so you would generally expect there to be kind of underproduction of red blood cells in that setting. Yeah, so I'm not sure. I'm not sure there. Yusuf, how would you interpret that?
I think I don't know if that's what Mark is alluding to, but it's very abnormal to have like a very elevated retic count in someone with end-stage renal disease. So maybe that tells us that the degree of the abnormality is severe. Like if there's hemolysis, the hemolysis is severe, or if they're having any loss, that would be severe because they have this degree of reticulocytosis, and even despite the low EPO, for example.
And then I guess to your question of transfusion, my inclination is that this patient would need a transfusion with a hemoglobin of 4.3. You mentioned, Mark, that I think early providers who saw this were hesitant to transfuse given the history of heart failure. I think that's a gap in my knowledge, like at what state of heart failure you would not transfuse if a hemoglobin is 4.3. So based off of my current state of knowledge, I would be inclined to transfuse. And then in terms of other things I would want to do like getting a smear as well. But then also for the abdominal distension, I think we still are not entirely sure if this is ascites or if this could be organomegaly. You said that it was kind of tense. You didn't appreciate a fluid wave, so I would want some type of imaging to understand, is there fluid in there? You could maybe start with a POCUS, start with an ultrasound, and maybe even get a CT scan to understand what exactly is causing the abdominal distension. Youssef, any other thoughts on what you would do next?
I think the things that, like you mentioned, I would get like a TTE, I get hemolysis labs and a smear as an initial workup, and then maybe an SPEP and a kappa lambda. We also note that the other thing I didn't mention was the gamma gap is also elevated here, if you notice, but it's not specific to anything in particular. It's just like general like inflammation, and then I would get like a HIV and hepatitis screen as well. And usually lupus can cause it too, obviously, but if there is like if a review system is positive, that's also something that you can screen for. And then if any of those is positive, then we can go down more workup for like hemolysis, and then we can go down like the Coombs route. But I think that those are the I would start with.
What did you do, Mark?
Awesome. Yeah, totally. So I ordered a unit of blood. And I mentioned that I was really like pressing the patient before about any signs and symptoms of volume overload. And that's not because that I wouldn't transfuse someone if they had like little if they had subtle signs of volume overload, but I just wanted to get a sense of their overall volume status. And their chest X-ray just looked like bibasilar atelectasis. Like I said, they weren't gaining weight. They were on room air, weren't in any respiratory distress. So I told the nurse, I'm like, this patient definitely needs blood, right? A hemoglobin of 4.3 definitely could worsen an underlying cardiomyopathy that she already has. So I said, let's give a unit of blood. We'll transfuse it slow and just, watch her volume status. And I don't know if luckily is the right word, but she does have a dialysis line. So that off chance that we needed to remove fluid quickly, we do have a dialysis line. Not that I, hope that it would get to that, but it was just like, we do have a backup, I guess, if that fluid really built up quickly. So I ordered a unit of blood. And then I went right for the CT, abdomen pelvis. And here is where it showed. So there is large volume ascites, some of which is mildly higher density than just frank simple fluid. And there is a mildly dysmorphic liver without frank cirrhotic morphology. And there is a hypoattenuating mass with central hypodensity at the dome of the liver measuring 8.5 by 8.2 centimeters. And I'll make that the last aliquot before the final diagnosis.
All right. Youssef, is it my app? I kind of forget.
Whichever you want.
Okay, I can take a stab at this. So we, from the CT abdomen, we're now have the understanding that this abdominal distension is in fact ascites. And, with ascites, I think the two questions in my mind is this fluid due to portal hypertension? Is this fluid infected? Mark gave us a lot of helpful information that, it's not tender to palpation. There's no fever as an example. But, if you just look at kind of the base rate of ascites, the most common causes are cirrhosis, cancer, and then congestive heart failure. If we kind of go down that base rate, we're not seeing evidence of cirrhosis in several ways. On physical exam, we're not seeing signs of chronic liver disease, pulmonary erythema, for example, spider angiomatous. We're not seeing thrombocytopenia. And then we hear from the CT abdomen that it's a dysmorphic liver, but no signs of cirrhosis. Cancer, I think, is still a question. And then for congestive heart failure, she does have a history of HFrEF, but we're not seeing signs of kind of worsening decompensation of the heart failure. I think, the liver mass is a new finding here. And if you think of like what could be the causes of a liver mass, malignancy is high on the differential, and hepatocellular carcinoma is just very common. There was an RLR that probably many of you listened to. That was a great discussion of kind of the base rate of liver masses and HCC, even in a patient without underlying cirrhosis, just by base rate is so common. So I would definitely be curious about hepatocellular carcinoma. Other kind of liver mass, you could have kind of benign ones, like focal nodular hyperplasia. My understanding is that that would still form a mass. And then you can consider like metastases, but kind of less likely with just this one mass and not multiple ones. So to the question, I think now the center of gravity here is what is this liver mass? But we still, I think, even if we understand what the liver mass is, I'm not sure I have an understanding of why there's a hemoglobin of 4.3. So that's still kind of a thread that I'm not sure how to tie into. But just given like the base rate of HCC, my understanding is that you can actually diagnose that without a biopsy. You can just based off of how it looks on imaging. So I would probably at this time just be doing some research to clarify exactly what the imaging findings are that allow you to make the diagnosis of HCC. I would probably call the radiologist to see if there's an additional type of imaging study we need to do to see if that is the diagnosis here. Youssef, what are you thinking?
Yeah, I'm just thinking like what an interesting pivot. Like we wanted the imaging, like what kind of swelling is this? And then we see like this huge mass. To start off, patients with heart failure can have like an artifact that looks like a mass, and then it turns out not to be a mass. I don't think this is the case here. I don't think Mark is presenting a case of artifact, but just FYI, there is like described cases where the mass is just like an artifact that can be seen on imaging because of heart failure, because of the congestion. Sometimes it can look like a mass. And then, like you mentioned, Maddy, I'm also wondering whether this mass is causing some form of portal hypertension just by compression of Mark was like, the hemoglobin is actually 14. Just kidding. If the mass is causing a portal hypertension and compressing the portal vein, and then the question is, what is this mass and is it related to the hemoglobin? So if it's malignant, like you mentioned, it's HCC, the pathway from hepatitis to liver hepatocellular carcinoma is much more common than spontaneous hepatocellular carcinoma, although it is possible. And then if you have hepatitis, you can get hepatocellular carcinoma without going through cirrhosis as well. So that's one thing. The other thing is, could this be the non-malignant lesions like you mentioned, focal nodular hyperplasia, or could this be like a hemangioma that can bleed while the patient is on apixaban? So that's good. And then like you mentioned, these diagnoses are all made on imaging, and then depending on the phase of contrast, you can try to diagnose it. And then there are things that are like non-malignant and that are like infectious, for example. So there are like bacterial abscesses can form, granulomas as well. And then things that are sterile, like giant cell arteritis, can cause it. All the causes, there are a bunch of parasitic causes, and then all the causes of culture negative endocarditis, like Bartonella, Coxiella. And then the other things that, or sarcoidosis, for example, all of these organisms that cause liver abscess or liver lesion typically don't cause hemolysis. I don't think necessarily they need to be the same organism, but the infections that cause hemolysis as well, like are Clostridial infection, Bartonella as one etiology, and then other things like rare things like severe leptospirosis that we don't see here either. So what I would do here is I would still want an echo to see if the degree of heart failure. I would get like blood cultures and try to see if we can get the diagnostic para, for example. If we see blood, that's our diagnosis. Basically, we're thinking of bleeding, and then the other thing is getting an ultrasound or a better imaging of the liver lesion. It might need an MRI as well. And I think these are my thoughts. I would want to rule out like bleeding to the abdomen with the apixaban use. Yeah. Anything else you would do, Maddy?
I loved your discussion, and I think just emphasizing a point that you just made that also Andrew commented on, like the CT admin commenting on large volume ascites with some areas with higher density. I think I definitely am suspicious for, is there some type of bleed in the abdomen, exactly as you said, on apixaban, higher risk, and that would probably explain the hemoglobin of 4.3 as well.
Yeah, I agree. The other thing is there is like an INR that can be checked without apixaban, and there are some like specialized centers that have like an apixaban level. I don't have it in my institution, but that's something that's coming out in the future that could also help you grade the degree of bleeding in the patient on apixaban.
Hmm. All right, Mark, back to you.
Yeah, awesome discussion. So yeah, I would say I had my management reasoning hat on for a lot of this, especially in the beginning in the ER. So I like rushed to call the radiologist, and I was like, hey, is this blood? Like, because when you have a hemoglobin of 4, just like your guys saying, you want to rule out bleeding, right? That's the thing that's going to kill you faster than, hemolysis or other causes of like chronic anemia. So, and I had in the back of my mind, like you guys said, this patient's on apixaban, because anytime you think bleeding, then you want to take it one step further. It's like, reverse any, coagulopathy or reverse any medications that the patient's on. So I called the radiologist. Like, yeah, we're kind of concerned with that higher density, that a significant amount of the ascites could be blood. But let's get a CT triple phase, CTA triple phase to better characterize that liver lesion for the most common causes, Maddy, like you mentioned, and use of HCC, which can be diagnosed based on imaging because it has such characteristic features. So I put that in stat. Stat, in the busy ER doesn't always mean stat, and sometimes it could take a little bit of time. So I was also in this gray period that this patient has a hemoglobin of 4.3. They're a little confused. They're a little tachycardic. And they potentially could have a huge amount of blood in their peritoneum right now, and I won't know for a little bit of time. So I actually went when I gave them adnextic alpha to reverse the apixaban, because I just think like the benefits just outweighed the risk. There is a risk of clotting with adnextic alpha, but I think with how low the hemoglobin was and some of the hemodynamic changes, like the RVR started to get like a little worse. Like it was in the 120s and kind of sustaining. Blood pressure was holding off, but I thought, like I said, the benefits outweighed the risks. And then the CTA came back triple phase. With features highly consistent with hepatocellular carcinoma, with bleeding into the peritoneum. So it's not like it seemed, it was a really hard read. The radiologist went back and forth, and we talked to the interventional radiologist as well, but there seemed to be bleeding from the HCC itself into the peritoneum. So yeah, the diagnosis is HCC with hemoperitoneum.
Wow, Mark, this was such an awesome case, and I feel like you presented it so brilliantly. Like I feel like I could kind of feel kind of the tension points you were at every different stage of this. So just absolutely amazing. Just kind of reflecting on it, I'm curious if the abdominal distension, of course, I'm curious if you think there were like multiple reasons for it. Do you think that the HCC was, causing like portal hypertension, and then so there's some ascites there, and then also bleeding, like two reasons why there is abdominal distension?
Such a great question. Because I struggled with that as well, because it said a significant amount of abdominal pelvic ascites, but like I think it was Youssef that mentioned, like this patient's heart failure has been stable. They've been getting dialyzed Tuesday, Thursday, Saturday, no issues with that. So like I was, my suspicion that the patient had volume overload from a heart or kidney perspective was pretty low. There wasn't really any signs of cirrhosis really on labs, and even on the CT abdomen and pelvis. So I think that the ascites was either from, maybe some worsening like right-sided heart failure, because the repeat TTE did show a little more of RV dilation and continued severe TR. It seems like this patient has a component of primary TR, tricuspid regurg, not just from secondary, from like annulus dilation from a dilated cardiomyopathy. So maybe cardiogenic ascites from like severe TR, in addition then that just low sag ascites from new hepatocellular carcinoma, but a significant amount of that fluid was from blood. And the thing I went back and forth in my head during this whole entire case. One of the nurses, a couple of the nurses asked me, they're like, "Are you a new ER attending?" Because I think I was in the ER for like 6 hours, but it was a lot of fun. But was the reticulocyte count like just like was blowing my mind, because like I was like, how many patients do I see with like, I kind of am a little bit of a hater of the reticulocyte count in general, because I think that's my inpatient bias, because I think patients in the hospital have such sick bone marrows that classic distinction of anemia being hyperproliferative and hypoproliferative usually doesn't pan out well in real life, because I think 99.9% of my patients I've had with hemolysis and bleeding have a hyperproliferative reticulocyte count, because they have concomitant ESRD leading to low EPO. They have concomitant iron deficiency anemia, B12 deficiency. So it like usually just doesn't work out well. But so this patient with ESRD heart failure having a reticulocyte count of 126,000, I was like mind blown. Like they don't even have EPO. They're not even getting EPO. How can they mount reticulocyte count from that? And then I was like, this has to be hemolysis. Like I've never diagnosed bleeding personally based on a reticulocyte count. So I'm like, this has to be hemolysis. And the AST was out of proportion to the ALT, right? The LDH was a little up. The T-Billy was slightly elevated to 1. I got the fractionation the next day, but then yeah, the haptoglobin being normal. Like Andrew said in the chat, sometimes haptoglobin can be an acute phase reactant. So I went down the whole hemolysis pathway. That was all negative. And then, obviously I found out that this patient had a lot of blood in their peritoneum. And then winded up getting 6 liters of bloody ascites taken out of their abdomen a few days later. And they actually had a TACE procedure, transarterial chemoembolization of the HCC a couple days later. And they left the hospital, doing well with follow-up for HCC. But yeah, I went down this, I was like, this had to be hemolysis based on the retic. And I'm like, but I have to remember, we have to rule out no missed causes of a severe anemia, which is bleeding. So I was like, I need to convince myself that this isn't bleeding. So that's why I got the CT really quickly. Yeah.
Wow, thank you so much, Mark. Yeah, I similarly love the way you presented and the way you presented it. Did we ever find out the patient had any risk factors for HCC, like the hepatitis panel, things like that?
Yeah, so a full cirrhosis workup. They had a full cirrhosis workup, which was negative. Their BMI was 32, and they had hypertension, hyperlipidemia, pre-diabetes. So base rate, they probably had, I guess now it's called MASLD or metabolic associated liver disease, in addition to severe TR and probably, a little bit of cardiac cirrhosis. I guess technically not cirrhosis, but based on imaging and labs, but liver dysfunction from heart failure. But even this patient, like you just said, classically patients go from cirrhosis to HCC, but not all patients do that. Classically, patients with Hep B or I think Wilson's disease as well can kind of skip over the cirrhosis and develop HCC early. But this patient didn't have any of those. But I think it was kind of an atypical progression of the liver disease.
Mark, this is such a phenomenal case. Thank you so much for presenting. And Mark, anything else you wanted to kind of emphasize from taking care of the case before we pass the mic to Parisa?
Yeah, I think Robbie has talked about this before too, but just remember HCCs love to bleed. So anyone that has cirrhosis or underlying HCC at baseline and they come in with severe anemia or an acute abdomen, just make sure they rule out hemoperitoneum because they're just very bleedy cancers.
Yeah, definitely. All right, Parisa, mic to you.
Oh, very interesting case. We talk about everything. We started with a patient who presented with abdominal distension, and she ended up to having hepatocellular carcinoma. Unfortunately, we initially talk about abdominal distension, and we know that it arises from various causes, including liquid accumulation, such as ascites, hemoperitoneum, peritoneum, or urinary retention. It could be due to solid enlargement, like organomegaly, or it could be from gas, from accumulation of the gas, from intestinal obstruction. Our diagnostic approach would be bladder scan for ruling out any urinary obstruction, or it would be evaluation for sign of chronic liver disease, or having ultrasound to detect any presence of the fluid. Then we talk about common subacute condition or urgent consideration of this presentation. We learned that the most frequent and subacute condition, including cirrhosis, which may manifest with or without pulmonary hypertension. We know that heart failure is another significant concern, which is characterized by symptoms like worsening of dyspnea and exertion and weight gain. Condition like intestinal obstruction might not be overlooked, as they are no misdiagnoses. We talk about differentiating with different type of the weakness, because we know that asthenia is usually involved generalized fatigue without neurologic deficit, versus neurological lesion, they are presenting with localized symptom and require a stroke than more acute intervention. We talk about approaches to anemia that may result from bleeding, loss of the blood. It could be due to GI tract, gastrointestinal bleeding, or any internal bleeding. It could be due to hemolysis, which indicated with low haptoglobulin, elevated LDH, or indirect bilirubin, or it could be because of the underproduction, which is noted with when bone marrow, when the many cell lines are low. And our diagnostic measure, including assessing the rate of the hemoglobin drop, we could get blood smear and retic count, and level of the ferritin could be also helping us. We also talked about markers of the cirrhosis, and that there are low platelet, low albumin, low haptoglobulin. We also learned that usually active, when we are having active hemorrhagy, patient having severe other accompanying condition like tachycardia. We talk about patients with ESRD, which are having when they are having anemia. The reason for that is underproduction, because they have insufficient erythropoietin, and when patient having peritoneal dialysis, they might experience abdominal distension. We talk about different type of the macrocytic anemia that could be megaloblastic due to B12 folate deficiency, or it could be non-megaloblastic, which is associated with chronic alcohol use, liver disease, or hypothyroidism. We also learned that 20% of myeloma could also present with macrocytic anemia. We also learned that copper deficiency could be finicky and could be present with macrocytic, microcytic, and normocytic as well. We also learned about the ferritin level, that high ferritin could be, high ferritin for us, low transferrin saturation is the indication of anemia of chronic disease, while low ferritin for us, low transferrin saturation is the indicative of iron deficiency anemia. We talk about also most common cause of the ascites, which are cirrhosis, cancer, and congestive heart failure. For liver masses, differential diagnoses are usually ranges from malignancies like hepatocellular carcinoma, and we learned that the biopsy may not be necessary, and the conclusive imaging should be enough. And we also talk about that hepatocellular carcinoma in patients with hepatitis may progress in patients with hepatitis, hepatocellular carcinoma may progress directly without the intermediate step of the cirrhosis. We also learned that we could use antioxidant alpha to reverse the effect of an anticoagulative effect of the apixaban. Thank you so much for this amazing session.
Harissa, you did not miss one teaching point. That was amazing. And I love how you organized it in such a clear way. Amazing job. Julia, thank you so much for scribing. And Youssef, this was such a blast to co-discuss with you.
Yeah, thank you so much, Parisa. Love it, Maddie. Let's do it again soon.
Definitely. Nice to see you all. See you next time.